2, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. What do you think? You ready? All right, hit the button. Yeah, I'm good right here, I think. Okay, hi. Hello, everyone. Nice to see you on this Wednesday afternoon. I'm Catherine McDermott. I think most of you know me. I am a psychiatric mental health nurse practitioner, and I'm also a co-owner here at Town Square. And today we're going to talk about managing challenging behaviors. Right? So we'll go through the presentation like I normally do. Feel free to stop me if you have questions along the way. And then at the very end, we'll talk about any questions or answers or scenarios that you might have that you want to talk about. Okay? All right. So basically, by the time we're done today, you should have a basic understanding of the cause of behaviors, how to respond to challenging behaviors, and prevention and caregiver support, which is how we end everything, right? And I always start off, my caveat always is, I know that you all are doing a tremendous job. And oftentimes it feels like I'm up here asking you to do more than you're already doing. My goal is not necessarily to give you something more to do, but to give you tools so that the caregiving role for you should be easier and not more difficult. All right, this is a quote that when John and I started Town Square really resonated with both of us, right? That the person with dementia isn't giving you a hard time. They're having a hard time, right? And it's because they're having a hard time that the behaviors begin, right? So as I was preparing this talk, one of the things that I think of all the time as a nurse, right? When I see a patient and I evaluate a patient, I do something called a root cause analysis. I'm trying to find out what the reason is for what's happening so that I know that my intervention, my therapy is going to meet the expectation of what's wrong with that person, right? So when we look at dementia, we have behavioral and psychological symptoms of dementia. So this is a completely separate field than the diagnosis of dementia, right? So neurologists, and we've talked about this before, many times people go see the neurologist and they're like, oh, the neurologist didn't do anything. Well, what is the neurologist really supposed to do? The neurologist is supposed to evaluate what's the reason this person is having problems with their cognition. Do they have a brain tumor? Do they have too much spinal fluid in their brain, something called normal pressure hydrocephalus? Do they have cognitive impairment due to Alzheimer's disease? Do they have Parkinson's disease? That's the neurologist's job. Their job is for you to walk out of there with a diagnosis, okay? Now, as we've begun to develop some new treatments, like for Alzheimer's disease with the amyloid plaque removing medications, their second job now is to have some form of treatment. For many years, neurologists had no way to treat and nothing really to offer other than a few medications like donepezil, memantine, that sort of thing, right? Other than that, they'd say, got diagnosis, got Alzheimer's, here's some meds, see you in 6 months. And so people would say, well, they didn't do anything. Well, they did what was in their scope, what they were able to do, right? What happens as the person progresses with dementia is they really develop psychological symptoms. And that's why my role in psychiatry becomes more, not important, but more helpful as the person with dementia progresses. Because we can't treat their cognitive impairment, but we can treat the behaviors that go along with that cognitive impairment. So behavioral and psychological symptoms of dementia are an expression of distress. The person with dementia cannot communicate through conventional means due to cognitive or linguistic impairment. They can't articulate, they can't understand, so they can't tell you what it is that they're feeling or why they're behaving the way they are. Okay? So this shifts the attention from suppressing symptoms, right? We're not trying to suppress those symptoms. We're trying to figure out what they're trying to tell us. Because once we can figure out what they're trying to tell us, then we know how to treat that, right? So behavior is really a form of communication. We expect that the person with dementia is going to begin to have shifts in their mood, right? That they're going to have behaviors that are outside of the norm. I was just talking to a family member, and we were talking about the hunting and gathering stage, right? Where they pick something up from one room and they move it to another room for absolutely no reason, with no cause, with no understanding of, I think one family member told me the ice cream scoop was in the underwear drawer. Like, why would the ice cream scoop be in the underwear drawer, right? Not someplace she would have looked for the ice cream scoop, right? But again, these are the changes in behavior and the changes in actions that we begin to see when cognitively they're not understanding the stimuli that comes in or their surroundings around, right? Again, it's not done on purpose. And this is one of the hardest things that I have to teach families. And we all know that as we age, our personality style, our traits, they intensify a little bit, right? If we were always a little bit of a worrier, now we're a really big worrier. If we always were a know-it-all and we had to be right, we're even more of a know-it-all. We're even more stubborn and dig our heels in, right? Well, you throw cognitive impairment on top of that, and it makes it even worse. So sometimes families will say to me, well, he always did X, Y, and Z. And now he's doing this, so I think he's doing it on purpose. And I can't say I don't understand where that thought process comes from, right? That certainly makes sense. But I think very often we give that person more credit cognitively than they really can do these things. I think, again, some of it is a natural reaction, right? Nobody wants to be told they're wrong. Nobody wants to be told it's Tuesday when it's Monday, when you really think it's Monday, right? So some of that is just going to be the natural reaction of the person. And that's where we also have to sort of pick our battles and decide what's really important for us in terms of reorienting versus redirecting. This, I think, is the most important. Again, I always come up with one little pearl that I want you all to take away from this, okay? And today's pearl is that behavior is communication. I'm going to say that again. Behavior is communication. What I'm doing, I'm trying to tell you something in a way that I didn't used to communicate with you about, right? I used to be able to come up to you and say, I'm hungry, and it's making me hangry, and I need something to eat. I can't do that anymore. But I can be hangry. I can be irritable and fly off the handle about things and completely inappropriate in my reaction to things. And it's because I'm hungry. So the behavior is a form of communication. And unless we look at what our person with dementia is trying to communicate to us, we're not going to be successful in changing the behavior. Okay? Does that make sense? I got you all with me so far? Okay. So if we talk about why challenging behaviors happen, physical discomfort are triggers. They always are. Pain, hunger, illness, any type of a physical, I'm cold, I'm tired. I'm overstimulated. There's too much noise going on. So anything that's going to cause us physical discomfort is going to trigger a behavior. Okay? And that behavior may be something and again, the word behavior doesn't necessarily have to mean a bad thing. Now, some people will tell me when people come over, my loved one with dementia leaves the room and goes and sits by themselves in another room. Well, that's a behavior. They're self-isolating themselves because they're not comfortable in that situation. They're telling you something. If you go in the other room, you go, come on, everybody's in the other room, let's go. And you bring them back in that room, is that going to work? Because they're telling you they're not comfortable in that situation. We have to be Sherlock Holmes. We have to be detectives. We have to get to the root cause of why they're acting the way we are before we try to figure out what we're going to do to help that behavior. Because in that situation, the behavior is that that person has self-isolated. Okay. If they're comfortable in the other room, you go over and you say to Joe, why don't you go talk to Bill? He's by himself in the other room. And you send one person in to socialize with him. And you let the person with dementia lead. You let the person with dementia set the rules. You let them tell you what they're comfortable with. Now, if Joe goes in there and sits down with Bill and starts talking to him, Bill gets up and walks out of the room again, guess what? He's told you again, I'm not comfortable in this situation. But typically, if they've left the room because there's overstimulation, one person is enough for them, right? We can't take our person with dementia and try to fit them into our world. We have to get into their world. So I got onto emotional environmental factors. So overstimulation, fear. Fear is a huge motivator for behaviors. I don't understand what's happening. I'm afraid something's going to happen. You are not in my line of vision. You walked around the corner. I don't know where you are. I think something might happen to you. I'm going to be frantic because I don't know what's going on. Fear is huge, and it's very, very common with patients with dementia. They are upset and fearful pretty much daily. We have members that walk up to us. Do you know where my wife is? Have you seen my kids? I know my car's in the parking lot. They're afraid that they don't know what's going on, and they're looking for that reassurance. Confusion, similar idea. Nobody likes to feel confused. Nobody likes to feel like they don't know what's going on. Nobody likes to not know what to anticipate next, right? And so this is also where I've talked in many of my talks about limiting information, small amounts of information, not too far in advance. Because if I tell you we have a doctor's appointment Tuesday at 2 o'clock, and all you can remember is that something's happening Tuesday, what did she say it was? And now I'm anxious because I'm confused and I don't remember. And I'm going to get irritable and have behaviors because of that, right? Oh, look at that. There's my unmet basic needs. So there's that on the other side. So we have physical discomfort and unmet basic needs. So this is hunger, thirst, boredom, loneliness. Now, boredom is a tough one because many, many times people will tell me that their person with dementia is very happy to just sit and stare off into space. Are they bored? Well, they're not really bored if they appear comfortable in that moment, right? So if they're sitting in their chair and they're sort of relaxed and they're kind of looking off into space and they don't look like they're distressed, then that's not a behavior. They might be bored because nothing's going on. Boredom where they're wandering from room to room and picking up things and moving them from place to place, or following you around like they're velcroed to you. That's boredom, right? That's, I need something else to stimulate me and to get my attention, because all I can think about is I don't have anything to do, so I'm going to follow you around. Does that make sense? Again, a lot of this for this, and when I do these talks and I think about these things, is us adjusting our expectations of what the person with dementia can do, right? Because if our expectations are of the way they were prior to them becoming cognitively impaired, we're setting ourselves up for failure as caregivers. We have to recognize that they can't do these things anymore. And so when we adjust our expectations, oftentimes their behaviors become less of a behavior and more of just their normal day-to-day life, right? How they react to things, because they're really not a behavior. They're their way of communicating with us what it is that they're feeling, what they're thinking, what they need from us. Okay, so now we get into the responding to challenging behavior. I've talked about this before. I know many of you have heard me say it. When you tell your person with dementia something, 15 seconds. You all know how long 15 seconds is? That was 10 seconds. Pause. The first thing you're going to want to do is react, right? It's natural. They're yelling at you. They take a swing at you. You're trying to just get them to go in the other room. They're doing something that's unsafe for them. Pause. Take a step back. Take 4 deep breaths in through your nose, out through your mouth, and just let it sit. The one thing that everyone who has dementia has is short-term memory loss. And sometimes in that minute that it takes you to step back and take those 4 deep breaths, they will have lessened in their memory of what exactly was just going on. And your chances of being successful at redirecting them goes up exponentially. Okay? Calm tone, right? This is where a lot of times I hear people say, she yells at me. She tells me what to do all the time, right? Again, you're not trying to tell them what to do. If they knew what to do, you wouldn't be telling them what to do, right? I mean, who wants to follow their loved one around and have to tell them what to do? Nobody wants to do that. But we have to look at how our tone is. We have to look at how we come across. People with dementia are highly sensitive to our facial expressions, the tone of our voice, how quickly we're trying to move, right? I'm caring for a family right now who the wife is 58 years old, Alzheimer's dementia, very impaired at a young age. And the husband went 5'8". The husband went off skiing with his sons, and the stepmother came in to take care of the patient while the husband was gone. And she said, the one thing I did when everybody left was I let things be quiet and settle. She takes her shower in the morning. She says she sits down at the table, and I dry her hair slowly. It takes me a half an hour to dry her hair. And in that time, the entire mood of the house changes. Now, we're busy. We're rushing. We got doctor's appointments. We got places to go. We got things that we got to do. If I can give you another pearl, you cannot rush somebody with dementia. Right? If it normally takes a half an hour, it's going to take an hour. And if you're prepared for that, you're not going to have a behavior because you're going to give them time to process the information. You're going to give them time to give you whatever feedback they want to give you. And you're going to listen and you're going to smile. It's one of the things I do here with the staff all the time. They'll come get me and say, I can't get Susie to let me take off her brief. And I'll go in and I'll get right up to Susie. And I'll smile. It's hard. It's hard to be angry with somebody who's calm and speaks to you softly and makes really good eye contact with you and smiles. These are the things that take extra time for you guys right now, extra effort. But getting into a behavioral tug of war with your loved one who has dementia is going to be harder on you. So if you start making these things part of your everyday, right? When you have that loved one who asks you the same question over and over and over again, and your answer sometimes is, I don't know. When are we going to eat dinner? Well, you can answer 5 o'clock. They're not going to remember that. And you can say it over and over and over again, but sometimes the answer is, I don't know. We don't like living in a world of unknowns. We want to be able to give that person that reassurance. But sometimes the answer really is, I don't know. And it's okay to say that. It's okay to live in that world with them where there's some uncertainty. We don't always have to have all of the answers for them. Okay? Again, your calmness will influence the entire interaction. And I know that all of you know this, right? You know when you get elevated, you know when you raise your voice, that it just doesn't go well. And that's where, unless the person with dementia is imminently in danger, walk away. They could be standing there with pee and poop and they need to get in the shower. They've already gotten it on the floor. They've already gotten it on the wall, whatever. They're agitated with you. They don't want you to help them at the moment. Leave them. Walk away. Take a deep breath. Allow the situation to de-escalate and go back and try it again. The more you push, the harder it's going to be, and the less likely you're going to be successful in your interaction. So we talked a little bit about this already, but we're going to kind of go over it again. So we talked about all of these things. So how do we look at these things? So how do we determine, right? And I liken it a lot to when we were raising our children and we had to figure out, are they hungry? Are they in pain? Are they tired? Like, what's their issue, right? Most of the time, we know, and we haven't fed them in a little while. And I'm going to tell you, food is your number one friend when you're dealing with somebody with dementia. We all love food. Food is our comfort. It is love. It's a distraction. It's a reward. It feels good when somebody gives you a cookie, right? And it doesn't have to be a big snack. It could be a handful of pretzels. But food is a huge distraction and will very often help you break a cycle of a behavior that you just can't get them to, we're going to do that. Let's go get a snack first. I can't tell you how many times we had a whole cabinet full of snacks back there that we use that here at Town Square, right? because that snack makes them feel taken care of. It meets a need. It brings up their own natural endorphins. It just kind of breaks whatever that cycle of the behavior is. So food is always positive. And I know, people are like, well, I can't give him a cookie every single time. He's going to weigh 300 pounds, right? And I understand that. But that's why I'm saying it doesn't have to be a lot. It could be a handful of pretzels. Okay? Carbs are always the best, though. Physical pain. So, hey, I know how old I am. When I get up in the morning and I'm like, ugh, gotta stretch, right? People with dementia don't perceive pain the way regular people do. Things hurt more. So if they're irritable, if they're grimacing, they go to get off the couch. They're not going to say, gee, my back hurts, because that's a complex thought. That's my back hurts, I'm standing up, I recognize my back hurts, and I'm going to articulate that to you. That's a lot. That doesn't happen. What happens is you say, come on over for dinner, and they go, leave me alone, I just stood up, right? Because they're uncomfortable. So look for facial grimacing, look for slow movement, look for shuffling, look for they're not their normal self. Can oftentimes be physical discomfort. Tylenol is a fairly benign medication. A little bit of Tylenol a couple of times a day. Oftentimes when I have people who tell me he won't sleep or he can't sleep through the night, I tell them add a Tylenol before they go to sleep. It's uncomfortable to lay in a bed at night when you're arthritic and old. Okay. One of the other basic needs that very oftentimes gets overlooked. Anybody know what it might be? Constipation. Nothing will irritate a dementia patient more than feeling like they have to move their bowels and one, not know where the bathroom is, not be able to go, or just generally feeling bloated and unpleasant. Constipation. A lot of times I ask family members, how is your loved one doing in the bathroom? Well, I think she goes every day. This is where you have to get a little bit more involved. You got to know what's going on in terms of their bowel movements. And as they move into the later stages of the disease, they're going to need some more assistance with these things. And we're going to want to know how often they're having bowel movements to make sure, right? But if you think about it, and you haven't realized that they haven't had a bowel movement in a few days, and they're really acting irritable, or you look at their tummy, and all of a sudden their tummy's, distended and firm, you might realize that they haven't had a bowel movement. So really important. So bathroom, hunger, temperature. I already lowered the temperature the last time we were in here. It got up to like 76 degrees, and I was like feeling a little